on behalf of my co-chair, Connie Kellum, and the entire DoxyPEP study team, we want to thank the organizers for allowing us to present here the findings of the DoxyPEP study. These are our disclosures. So we know there's a global epidemic of STI infections in the US and indeed around the world. And unfortunately, these disproportionately impact men who have sex with men and transgender women, particularly those who are living with HIV or who are taking HIV PrEP. We know that doxycycline taken after condomless sex as a post-exposure prophylaxis, or PEP, is a promising intervention. An earlier investigation in the Ipergay study and others has shown that doxycycline PEP led to a 2/3 reduction in syphilis and chlamydia in MSM who were taking intermittent HIV PrEP, but was unfortunately not effective for gonorrhea. In order to better investigate and understand the strategy of doxycycline PEP, both in people living with HIV and in those taking HIV PrEP, we designed the DoxyPEP study. The eligibility criteria included male sex at birth, living with HIV or on HIV PrEP, having one or more bacterial STIs, which were limited to syphilis, gonorrhea, and chlamydia in the past 12 months, and condomless sex with one or more male partners in the past 12 months. We designed this with 2 separate cohorts with the planned enrollment of 390 for those living with HIV, as well as 390 for those living with taking HIV PrEP. At the time of enrollment, they were randomized 2-to-1 to receive open-label doxycycline, 200 milligrams, taken as PEP as soon as possible, but within 72 hours after condomless sexual contact. And the maximum was 200 milligrams that could be taken every 24 hours. At the time of enrollment and every 3 months afterwards, as well as indicated, our participants were tested with NAT-based testing for GC and for chlamydia, as well as for syphilis using serology in the blood. And at the time of gonorrhea diagnosis, we attempted to get a gonorrhea culture before treatment. Individuals were followed for 12 months and had every 3-month visits while on study, as well as visits if STIs were diagnosed in the interim. This study enrolled at San Francisco and Seattle HIV and sexual health clinics. Our primary endpoint was at least one bacterial STI, gonorrhea, chlamydia, or syphilis during each follow-up quarter. All of our STIs were adjudicated by a blinded endpoint committee. We had an 80% power to detect a decrease in quarterly STI prevalence from 10% to 5%, powered separately by PrEP and people living with HIV cohorts. Our planned stopping rules were only if both cohorts crossed stopping boundaries for proven effectiveness based on a one-sided alpha of 0.25. In May of 2022, at a scheduled interim analysis, our DSMB recommended stopping enrollment due to significant effectiveness in both cohorts. They recommended that the study continue and that we offered doxycycline to all of those enrolled in or assigned to the standard of care arm, which we have done. The data that I'm going to present to you today are from an intention to treat cohort for individuals enrolled up to May of 2022 who had at least 1 quarter of follow-up to contribute. I want to just highlight a few pieces here. The age in general of those on PrEP was slightly lower than those living with HIV. Overall, the median age was 38. The majority of our individuals identified as male, although we did have about 5% who identified as trans woman or gender diverse. On average, there were a median of 9 sexual partners reported in the past 3 months, and substance use was common, including 30% taking stimulants, 32% reporting ecstasy, GHB, or ketamine in the last 3 months, and 45% reporting use of amyl nitrates or poppers. Our primary endpoint was STI incidence per quarter, and I'm going to start by looking at the PrEP cohort. And you can see that there was, in the standard of care arm, almost a 32% incidence of new STIs per quarter that reduced to 10.7% with assignment to DoxyPEP. This was statistically significant for a reduction of 66%. Similar findings in the HIV cohort, where 30.5% in the control arm had an STI per quarter, which went down to 11.8% with the use of DoxyPEP. And this was a 62% risk reduction, which was also statistically significant. And overall, we saw a 65% reduction in STIs per quarter. You can see in the blue bar that gonorrhea was our most common STI, followed by chlamydia, followed in green by syphilis, and some individuals were diagnosed with 2 or more STIs per quarter, as indicated in black. As expected, most of our STIs were asymptomatic, However, there was a trend towards less symptomatic STIs at the time of diagnosis in the doxy arm, about 15 to 17% with symptomatic STIs, versus those in the standard of care arm with 24 to 28% with symptomatic STIs. When we look at each of the individual STIs by anatomic distribution, you can see that in gonorrhea, the most common STI we had diagnosed, there really was a mix of anatomic sites, including pharyngeal, rectal, and more than 2 sites indicated in black. For chlamydia, the majority of individuals had rectal disease at the time of diagnosis. Looking at individual STI incidence by study arm and by cohort, going back to gonorrhea, you can see that there was a statistically significant decrease in gonorrhea incidence in both the PrEP and people living with HIV cohorts. It was 55% in PrEP and 57% in people living with HIV, and this was statistically significant. The decline was even more pronounced in those who were diagnosed with chlamydia, with an 88% reduction in those on PrEP and a 74% reduction in those living with HIV. These were also statistically significant. You can see syphilis indicated in the green bars. We had very few cases of syphilis overall. There was a statistically significant reduction in those on PrEP and a trend towards a reduction in those living with HIV. DoxyPEP was safe, acceptable, and had high adherence rates. We had no grade 3 or more adverse events, no grade 2 or greater laboratory abnormalities, and no doxycycline-associated serious adverse events. 1.5% discontinued due to intolerance or participant preference. 88% reported that doxycycline PEP was acceptable or very acceptable. Participants reported a median of 7.5 sexual acts per month, and that 87% of these were covered by doxycycline by self-report. When we asked people how many pills they took, about a little more than half said they took less than 10 pills per month, 30% reported 10 to 20 doses per month, and 16 reported more than 20 doses per month. Gonorrhea tetracycline culture-based susceptibility was conducted through the CDC, SURGE, and ARLN programs. About 30% of our gonorrhea endpoints had resistance data available. The remainder didn't have resistance data because we either couldn't get the culture prior to treatment, or the culture didn't grow or couldn't be successfully run for antimicrobial susceptibility. For those who were diagnosed with gonorrhea around the time of baseline, you can see that 20% had tetracycline resistance, which is indicated in the red bar, and that correlates with an MIC of 2 or greater using agar dilution methods. While this is a small number, it is consistent with US surveillance numbers that we have from the GIST project, which also shows about a 20% tetracycline resistance in gonorrhea. This is important because population-level gonorrhea resistance in the US at about 20% was substantially lower than that was seen in France of about 56% during the conduct of the IPERGAY study. This may be one of the reasons why we found that DoxyPEP was effective in reducing gonorrhea, whereas we did not see a signal towards effectiveness in the IPERGAY study. You can also see in the DoxyPEP arm that there was a trend towards more resistant tetracycline that occurred during breakthrough infections. I think this likely indicates that doxycycline may have less efficacy in preventing pre-existing gonorrhea that has tetracycline resistance that's present, not that doxycycline was driving gonorrhea resistance to tetracycline. We have too short of a study for this to be likely, and we will need population-based surveillance for those taking doxycycline to really answer this question of what is the impact of doxycycline PEP on the development of tetracycline resistance in gonorrhea. So in summary, doxycycline PEP taken within 72 hours of condomless sex substantially reduced the incidence of bacterial STIs, with a quarterly reduction of 62% in people living with HIV and 66% in those taking PrEP. We also saw substantial reductions in the incidence of each bacterial sexually transmitted infection, including gonorrhea. It was well tolerated and had high self-reported adherence, and based on these data, we think that DoxyPEP has potential as an effective prevention strategy in populations with high STI incidence. In this case, we had 30% incidence per quarter in this study. As I mentioned, larger studies and ongoing surveillance are needed in DoxyPEP users to understand the impact of tetracycline resistance development in gonorrhea. And evaluation is underway to look at the impact of DoxyPEP on sexual behavior and antibiotic resistance, including in Staph aureus, commensal Neisseria, and the gut microbiome. I want to thank profoundly all of our study participants for their time, commitment, and their willingness to be randomized in this study. our funders from NIH, specifically DMID, and just an enormous thanks to this large and very committed team of investigators and study participants. Thank you.